Thank you to the conference organisers for inviting me to give this presentation today. My name is Andrew Grulich and I'm the head of the HIV Epidemiology and Prevention Program at the Kirby Institute in Sydney, Australia. And I'm presenting to you today on the experience of PrEP implementation and scale-up in Australia. So before I start my talk, I think it's important you're aware of the structure of Australia's HIV response. In Australia, we've been really fortunate in that our major political parties have treated HIV as a bipartisan issue. It doesn't get treated in the political sphere. It's very much a science-based response, free from political interference. We recognise a formal partnership approach, and this is written into all sorts of policy documents between government, community, clinicians, and researchers. And the response is guided by an overarching document, a national HIV strategy. We're up to our 8th national strategy at the moment, and they last anywhere from 3 to 5 years. That strategy is monitored by a ministerially appointed advisory committee of experts in the field and, very importantly, community representatives. And at least for the last few strategies, has been linked to having quantitative goals and targets. I'll come back to that. I think it's been a very important feature of our response. And the last important point about the Australian system is that, which is particularly relevant when we're talking about a pharmaceutical preventive agent, is that pharmaceuticals are funded in Australia based on a cost-effectiveness analysis. And there is a fixed price copay for the recipient at the point of sale of $40 per month, no matter what it costs the Australian government. The cost of the medication, the cost to the consumer is the same. And in fact, if people are unemployed or below a certain income level, they qualify for $6 per month pharmaceuticals. And so before PrEP, and we generally think of that in Australia as prior to 2016, HIV had been remarkably stable. It was a condition largely confined in Australia to gay and bisexual men, with more than 70% of diagnoses. And we had worked hard since the evidence came out on the efficacy of treatment as prevention in, around about 2012 to get testing and treatment levels. And in fact, by 2016 had reached 90-90-90. But you'll see on the graph here, the line of HIV diagnoses was stubbornly flat. So despite reaching those 90-90-90 goals, we had stable rather than decreasing diagnoses. I should say, though, we were relatively happy with that because around much of the developed world, and indeed in much of East and Southeast Asia, we were seeing increasing HIV epidemics in gay and bisexual men. So here's an overarching timeline, and I'll spend a little bit more time on the individual elements of this. We first got in principle support for PrEP use in Australia from 2012. This was after the 2010 publication of the effectiveness of PrEP in gay and bisexual men in South America in the IPREX study. By 2014, we had guidelines at small trials in a few settings. The government was very concerned about how widely used this might be, so we came up with some eligibility estimates prior to large trials and community mobilisation, which started in 2016. Those trials actually started before the drug was licensed. Before then, the manufacturer had not brought it to our Therapeutic Goods Administration. By 2017, we updated the estimates of how many people were eligible for PrEP and did some cost-effectiveness modelling. It was subsidised publicly in 2018, and since then, the availability has been expanded and the guidelines broadened, as I'll explain. So just going through those in some detail, the initial support, and the reason I'm taking some time over this is that around the world, access to PrEP has taken too long. We've had randomised trials for a long time now that shows it's been effective in many parts of the world. Uptake has been very slow, and at least initially that was the case in Australia. In our state HIV strategy between 2012 and 2015, it was noted that the clinical trial results were promising, but the language was very cautious, suggesting it would be a preventive option for just a small number of people at very high risk of infection, and that in this period, the health department would consider the application of the trial results. it's also worth noting that this was in the framework of an overarching goal of the virtual elimination, so a highly ambitious goal. And that was important, I think, because to get to those sort of ambitious goals, clearly ambitious implementation has to happen. So by 2014, we had our own local PrEP guidelines, which are very important, I think, and without guidelines, the clinicians in your location aren't going to know what to do. And they were based closely on the CDC guidelines. Those guidelines were then used in 3 Australian states in small-scale demonstration projects. They were of less than 500 gay and bisexual men in total. The first studies were focused on the highest risk gay and bisexual men. There was quite a bit of concern that it would be highly targeted. And the projects showed that demand was very high. None of the projects all recruited extremely quickly. They showed, in contrast to some of the initial trials of PrEP, that adherence was excellent. And this was a huge concern because, of course, if you don't take PrEP as prescribed, it doesn't work. And so the demonstration that it was excellent, that adherence was excellent in the Australian setting was critical. And we actually collected biological specimens to look at blood levels to prove that that was the case. And in about 500 person years, we saw not a single case of HIV infection where we would have expected many. So that was very promising initial data. Following on from those results, there was obviously a clamour to implement, but still real concern about how many people might be eligible. So essentially, we looked at this in New South Wales with estimates of the proportion of the population who identify as gay, which is about 2% in our National Sex Survey data, on behavioural surveillance data on the practice of condomless anal intercourse, which is our high-risk behaviour, and cohort study on study data on incidence. And the table at the bottom illustrates the documented incidence in various groups of gay and bisexual men in the Healthy Men study, which had been conducted the decade before. You see these groups had incidence of between 2 and 7 per 100 person years, and they became the guidance for our eligibility criteria. And the target was very strictly, at least initially, very strictly focused on this group, on the highest risk. Policymakers, it must be said, were nervous about this being used too broadly in the gay community when we'd had reasonable success in controlling infection, and felt that targeting the greatest impact is what we initially needed to do, and focusing on a relatively small number of eligible people. Our estimates, which were published in 2018, is that about 9% of sexually active gay men, and that worked out as 3,700 men in New South Wales, would be eligible for PrEP using these criteria. 2016 was or 2015-16 was a real watershed time in PrEP, because it was the year that data on 2 new randomised trials in gay and bisexual men were published. And that really led to a change in our understanding of just how effective PrEP is. So in both of these studies, in the UK and in France, showed that oral PrEP is virtually 100% effective in adherent individuals. And that led to our understanding, which is still our understanding today, that in fact oral PrEP, consisting of TDF and FTC, works best in the rectum, and is actually a highly forgiving regimen that it remains effective even if a person is only taking 4 pills a week, that is missing up to 3 pills a week. That's not the case for women, and daily adherence is required for vaginal protection. PrEP, of course, still does fail, but it's when people are not adherent, and case reports of failure in adherent gay and bisexual men remain very rare, with really a handful of such cases documented internationally, despite something like 500,000 people now having taken PrEP. Another important part of the puzzle, the policy puzzle about the introduction of PrEP, was what the modelling would show. And really, it's actually not rocket science when you have a preventive agent that's more than 95% effective at the individual level, that if you could target this to the high-risk gay men with high levels of coverage and roll it out quickly within a couple of years, you would see very substantial reductions in HIV, as shown in this graph of modelling data. And lower levels of rollout lead to much lower reductions in incidence, suggesting that it's not just the individual effect of PrEP, it is herd protection that is a critical part of the population level effect. So you prevent one infection, you then prevent passing the infection on to other people. And by preventing other people becoming infected, the prevalence becomes lower and you get, at least to some degree, herd protection. This was really important in convincing our policymakers that we should aim high. We shouldn't be tentative about this and just view it as an individual intervention. We should be aiming for reduction of HIV transmission at the population level. And that sort of approach was very much incorporated in the latest New South Wales HIV strategy, again targeting virtual elimination of HIV, which talks much more broadly about expanding PrEP access to all people at high risk of HIV infection, and not being much less tentative than the previous strategy. That led that desire to large-scale implementation trials around Australia, in which the one that I led in New South Wales, EPIC New South Wales, was the largest. There was real political commitment to do this quickly. This was done within a clinical trial framework because in Australia at the beginning of the study, the TDF-FTC had not been licensed, and because it was a clinical trial, we were legally able to import generics at much lower cost than the brand name drug Truvada, which was still very expensive in Australia. Our demand was extremely high in the study. We met our enrolment target of 3,700 within 8 months and made the decision to allow access without a cap to all people at high risk. And this was supported by some pretty amazing large-scale PrEP social marketing campaigns to the gay community. And nationally, we recruited about 16,000 gay men to such trials. Part of the next process in Australia is to demonstrate that the drug will be cost-effective at the population levels. And what these analyses showed was that at conventional levels of cost-effectiveness, PrEP should cost less than about $3,000 per year, 3,000 Australian dollars. So prior to April 2018, only brand name drug was available, and the cost of that was in the region of $10,000 per year, which is not cost-effective in any of the scenarios we looked at. Thankfully, at this time, off-patent versions of generic PrEP became available. The table at the bottom just shows you some of the scenarios we modelled, the first of those being that 30% of high-risk gay men would be receiving PrEP and no medium or low risk. And then the other three, much higher levels of coverage of the high risk, which is the ones you really want to target if you want population level benefit. So you can see, for example, for the 90% of high risk and no medium and low risk men, the cost of PrEP per year to meet a willingness to pay threshold of $30,000 per quality adjusted life year was about 4,000 Australian dollars. You can see a number of other scenarios. In the Australian setting, it's very rare for a preventive agent to go up to 60 or even 90,000 per quality adjusted life year. So our national strategy then in 2018, which is when it first became subsidised through our national drug program, was to promote, led to this key area of action to promote availability and effectiveness of PrEP, and for the first time inserted a quantitative target that by the end of 2022 we would increase the proportion of eligible men who are on PrEP to 75%, specifying there that it should be in combination with STI prevention and testing. So 2018 was the year we did transition to publicly funded PrEP. It was approved in April of 2018, and at that stage the access trials closed to new participants and people were transitioned to publicly subsidised PrEP. It was continued to be supported by large-scale social marketing, and I'll show you some examples of that in this talk. And then with the success that was emerging there and the declining price of PrEP, generic PrEP, those guidelines have been somewhat relaxed. So rather than saying that men had to report certain behaviours to be eligible, we now talk about people's risk being suitable, with more room for clinician discretion of who might benefit from PrEP. And the 2019 version of our guidelines now explicitly supports on-demand PrEP for cisgender, have sex with men. So some national data now on PrEP scale-up since the listing of the drug on our PBS, the Pharmaceutical Benefits Service. So the 16,000 men on PrEP trials were rapidly transitioned to the PBS if they wanted to continue taking PrEP, and most did, and many new men after 2018 were initiated on PrEP. As of the first quarter of this year, about 45,000 individuals in Australia have been prescribed PBS subsidised PrEP. You will note a substantial decline in the order of 20% in the second quarter of 2020 in relation to the COVID epidemic. Certainly, we have a lot of survey data that many men stopped taking PrEP for a while during the period of lockdowns across Australia due to COVID. By the second quarter of 2020, this had recovered pretty much to pre-COVID levels. Another way we monitor PrEP, and a part of our system is to monitor progress against that target, that national strategy target of 70% of high-risk men being on PrEP, is to monitor it through behavioural surveys in gay and bisexual men. And we have this system of annual gay community periodic surveys conducted by the Centre for Social Research on Health at the University of New South Wales, which has been going since 1996. It's a national system for behavioural surveillance. And one of the things it now tracks is the percentage of all gay men who are taking PrEP. And among those, we define those men who have had recent condomless anal intercourse with casual partners as being high-risk gay men. And so we track those proportions. And you can see then in the graph there that among high-risk gay men, we are approaching the national strategy target of 70%. But I'd point out in the grey dotted line that actually our new state strategy in New South Wales, which has just commenced this year, has a new target, an even higher target of 90% of at-risk gay men taking PrEP. So what about the impact? What have we seen in the EPIC New South Wales study, which recruited about 10,000 men over a little less than 20,000 person years? Our incidence rate was 1.6 per 1,000 person years. That's not a per 100 person year rate, that's per 1,000. So 0.16 per 100 person year. So we would have expected, in the absence of PrEP, based on historical data, an expected incidence rate of at least 20 per 1,000 person years, or 2% per year. And this is 92% less than that expected rate. We saw 30 seroconversions, and all of them were in men who were not taking daily PrEP at the time of exposure. So we saw no cases of drug failure. The medication possession ratio, which you can think of as the proportion of pills that you would have left in your possession if you were taking pills every day, declined to 64% by the end of the study. And this is a very common finding around the world, that over the years, gay men don't all continue to take PrEP daily. And those who stopped PrEP, thankfully, were those who were more likely to decrease risk. And in fact, among the men whose medication possession ratio was 100%, so in other words, they were taking all of their pills, we saw no infections. We were broadly more interested in the population level impact, and these data focus on HIV infections in New South Wales. A somewhat similar, although slightly less striking finding is seen nationally in Australia. The graph here goes to the end of 2020, but the percentage declines I've seen there, I've quoted there, are till 2019, before the COVID epidemic. We've actually seen more decline since the beginning of the COVID epidemic. So we've seen a 24% decline in HIV diagnoses in MSM overall after those years of no decline. We've seen more than a 40% decline in Australian-born men who have sex with men, and lesser declines in the overseas-born. we've also documented smaller declines in MSM who live outside the inner city and in the youngest group of MSM. And when we look at our behavioural surveillance data, we can see that those men definitely have lower PrEP uptake, and that's a focus of our current prevention efforts is to see higher PrEP uptake in those men. In the group who are doing best, that's Australian-born men who live in the inner suburbs of Sydney, we have seen more than a 70% decline, extraordinary declines in HIV infections in that population, which has the highest levels of PrEP use. And I think that shows us what's possible with PrEP if you get high enough levels of coverage. What about sexual behaviour? It is certainly true that we are seeing declining consistent condom use. And in this colourful graph here, the green colour represents, this is from our gay community periodic surveys, this is the proportion of all HIV of all gay men reporting each of these behaviours. So consistent condom use has declined a lot, and in yellow, the proportion of men who are on PrEP has increased enormously. So from a tiny proportion in 2016 to more than a third now. But what is gratifying is that the proportion who are prevented from have one or more effective prevention behaviours is increasing. So in 2016, about 30% of men reported condomless anal sex with casual partners that was likely to be high risk, and that had declined to 2020 to 20%. What about the impact on sexually transmitted infections? With declining condom use, we might, of course, expect increases in sexually transmitted infections. However, that effect is actually counterbalanced by increased STI screening and increased STI treatment, which reduces prevalence. In Australia, as around the world, the program, if you like, is quarterly visits to a doctor with STI screenings at every visit. And so the decrease in condom use appears to be counterbalanced by the increasing screening and treatment. So these are data from the EPIC New South Wales study of those nearly 10,000 men. STIs were very common at baseline, but the positivity rates over time did not change, no significant increases at all. So the concern that PrEP rollout in itself causes STI epidemic is, we think, unfounded. So to finish off with, just speculate on a few reasons why Australia's PrEP rollout has been so successful. It has certainly been helpful for us to have high-level political support and leadership, and talking about from the Health Minister down, it's been really gratifying in Australia that that's been able to happen. Having quantitative targets has been really important, because had we not decided that we should be aiming for HIV elimination in line with UNAIDS targets, we might have been quite content with flat levels of HIV diagnoses. But the fact that we weren't seeing declines meant we had to use everything at our disposal. Australia has a highly functional system of primary care, and so it is easy in Australia for people to access PrEP at reasonable cost, and certainly being able to access generic PrEP really revolutionised this field, because preventive agents that cost $10,000 a year are just not going to be affordable in any setting. We've spent quite a bit of attention on having good quality monitoring and evaluation showing impact, and this has been very important in maintaining support for what could otherwise be quite a controversial program. The fact that we've got well-funded, very effective HIV community organisations means that we really have quite a literate, mobilised and pragmatic gay community. And I really have to pay tribute to ACON, our gay community health organisation here in Sydney, which did an amazing job of educating community. There's a single example there, I'll show you a few more, but I think you could really summarise it in saying that the message was simple. It wasn't complicated. That simple message of PrEP prevents HIV in 2016 particularly was quite revolutionary, because until then it had been condoms, but letting gay men that there was another way to prevent HIV was critical. And that's been sustained. We haven't stopped promotion. It's been sustained and targeted since. I think you can't underemphasize the fact that it's not just PrEP. We have very high rates of HIV testing and very high rates of treatment as well. So those two forms of biomedical prevention, treatment as prevention, and PrEP coming together is part of our success. Now, some of you may be looking at this and thinking, well, that's never going to happen where I live. And perhaps some of that is true. But I really would like to emphasize to everybody, wherever you are, is that PrEP is a almost 100% effective intervention. And therefore, and that's wherever it's implemented, as long as people are adherent. It really is the case that PrEP delivery is clinically simple. We're trying to make it even more simple. This is a service that lends itself to task sharing, perhaps with nurses, perhaps even with peers, because this is a very simple, very safe medication that simply needs to be rolled out at scale. And that last point is that if we educate people about that simple fact that PrEP prevents HIV, people want PrEP. I still hear people saying, well, I don't know really that my population is interested in PrEP. But really, once people are told the truth about PrEP, that it's very effective at eliminating HIV risk, then they do want it. Just to finish up, I just thought I'd show you a couple of slides with some of our promotion. PrEP really became like wallpaper around inner Sydney for a few years, and these are a few examples of PrEP posters that in the first year of the rollout, we identified a concerning pattern that the proportion of gay and bisexual men who were born overseas, predominantly in Asian countries, who were on PrEP was lower than it should be, based on how many of those men were in Sydney. And so we went very broad with Asian languages, promotion in Asian languages, promotion also in Brazilian Portuguese, because we have quite a few Brazilians in Sydney, to really try to get more overseas born gay men on PrEP in Sydney, and had great success, so that by the end of the study we had really good rates of overseas born men taking PrEP. And the last image I want to show you is this important focus on combination prevention. It is not just PrEP. PrEP is a great part of the solution, but to have maximum impact on reducing HIV, it needs to be implemented in combination with behavioural prevention using condoms and treatment as prevention, and U equals U. And these images appeared all over the place around Sydney, including in train stations, and led to our really knowledgeable community at risk. And to finish with, I really just want to thank all my co-authors in Sydney from a number of institutions who have helped in this work, which is on the monitoring and evaluation of PrEP intake. Thank you very much. I'll leave it there.